Hello, everyone. Thank you for joining us for today's webinar. My name is Beth Cohen-King, and I'm the Marketing Director at Margolis Bloom. We work with our clients to find the best estate planning or elder law solution for each client's unique situation and goals. So today our presentation is very relevant and timely. COVID-19 legal and healthcare planning, brought to us by Dianne Savastano of Healthassist. She is the founder and principal of Healthassist, a Massachusetts-based company founded in 2004 that specializes in helping clients navigate the complexities of the healthcare system. And Harry Margolis, founder and co-manager of Margolis Bloom. There they are. So if you have any questions during the presentation, please type them into the question box in your control panel on the right side of your computer. We will have time for questions at the end. And if we aren't able to answer everything during the webinar, we will follow up directly via email. And for some reason, if you need to jump off, we are recording the presentation. And with that, Dianne, take us away.
Great. Well, thank you very much, Beth, and welcome to everyone. I am so pleased to have you all with us, and I saw a lot of familiar names on the list of attendees, so again, thrilled to have you here. I'm also thrilled to be presenting with Harry. He and I have known each other for quite some time and worked together in the past, so it's an honor to be presenting along with him.
Likewise, Dianne.
Thank you, Harry. Good. Well, we have all been experiencing this pandemic, and I would say that many of us are feeling quite powerless during this experience. I think it has been since about March 11th, about 9 to 10 weeks since I feel like our world was turned upside down. And we at Healthassist have been living through this, both personally, of course, but more importantly, with some real life experiences with clients who have either had COVID-19 or have been symptomatic, have been hospitalized, and unfortunately, we lost one client from COVID-19. So our objective is to share some experiences with you in order to give you some sense of control and also to help you to plan. This is really about planning. So you could go ahead to the next slide, Beth. In terms of our agenda for today, we will briefly be discussing COVID-19 and what it is, and again, focus in on planning. I will really focus in on planning for hospitalization and sharing with you our suggestion for the development of what we call a grab-and-go kit. But not only will we be planning for that, we'll also be planning for what if you have symptoms? How do you manage them? What if you are positive for COVID-19 or someone in your family is? How do you care for someone at home? And what if you do have to go to the hospital or a loved one has to go to the hospital? How do you manage that? And then I'll be turning the program over to Harry to really talk about legal planning. So big theme of planning here. You can go on to the next slide, Beth. In terms of COVID-19, as we know, it was the disease that was, it has come from the coronavirus. It was discovered in China in December, and the World Health Organization declared it a pandemic in March of this year. And it is a disease that spreads quite quickly through respiratory droplets. And so it's quite a virulent virus. And what happens is that it can cause what we call an atypical pneumonia. And that atypical pneumonia can cause an incredible reaction in the body. We'll get to that in just a second. This happens to spread much more efficiently than the flu. And so thus we have been asked to take huge precautions so that we don't share it amongst others. You could go on to the next slide. Beth, I can't see the slides moving, so forgive me, but I'm assuming we're on the COVID-19 symptoms slide. On this slide, you'll see... I'm sorry?
Beth needs to go back one slide.
Oh, okay. So I don't know why on my computer it's not moving, so bear with me. So in terms of the COVID-19 symptoms, you'll see that there's a lot of busyness to this particular slide. And I did this on purpose. And you'll see that there are different colors for the various symptoms. The first three that are purple are the original symptoms that were listed on the CDC website: the fever, the cough, and the shortness of breath or difficulty breathing. But a couple of weeks ago, they added 6 more symptoms, and you'll see those in blue. And then you see the symptoms in red, and that indicates that this could be becoming an emergency situation. Things like trouble breathing, persistent pain or pressure in the chest, new confusion or inability to arouse, bluish lips or face. So and then the ones that are in black are others that we've seen, and I thought they should just be listed on here. And the point I really wanted to make about this slide is that you could be completely asymptomatic and not have any of these and still be transmitting the virus. And you can see that you can have one of these, you could have 2 of these, you could have all of these. I think what I really wanted to have you learn from this slide is that you need to really pay attention. You need to pay attention to your body. You need to pay attention to others if you're responsible for others. And you especially need to pay attention if symptoms develop and someone also has some coexisting medical conditions, because that may predispose you to having COVID-19 and or having a more virulent case of COVID-19. So the things we think about are people who have hypertension and heart disease, or they have diabetes, or they have underlying respiratory conditions like chronic obstructive pulmonary disease or asthma. Or maybe they're immunocompromised because they're undergoing cancer care, or they have an autoimmune disease. Now, that all being said, there are plenty of people who've become very sick with COVID-19 who did not have these underlying conditions. So again, you really have to pay attention to yourself and to your body. And again, pay attention to someone in your life that you might be caring for. I mentioned that this causes an atypical pneumonia, and what we are seeing is that this atypical pneumonia presents with what they call this cytokine storm, which is a sort of major inflammatory response and reaction in the body. There's a lot of information that's being gathered along the way here over these last 9 weeks. And one thing I wanted to mention is this inflammatory response we have found may be causing some clotting issues in the body. And so that new confusion or inability to arouse or signs of stroke, that's because clotting has become a problem, and stroke seems to be occurring and often in younger people. The other one about the persistent pain or pressure in the chest could be because there's a clot that is now causing what's called a pulmonary embolism. So again, major inflammatory reaction in the body that could be contributing to these symptoms. Now, when we first sort of just went into full-blown emergency mode about our clients, and we were thinking about planning for each and every one of them, we kind of stratified them in different buckets. And so I ask you to think about people in your life, think about yourself and think about people in your life. And so we obviously did different planning for someone who lives alone but has some family support around them. So, I'm thinking about my 85 and 86-year-old parents. They don't live alone, they live with each other, but I'm also their family support. But we have clients who live in the community, live completely alone, and really have no family support. So that was the next category. And then we have a lot of clients that we have to think about who might live in a community setting. So what I'm referencing here is people who live in maybe an assisted living environment, or maybe they live in a continuing care retirement community, or maybe they live in long-term care in a traditional nursing home, because you plan differently for those different scenarios. Now, in the beginning, we also thought, okay, well, what do we do first? And so we looked at people's medical appointments, and we thought, okay, so who has essential medical appointments that we need to work our way through? And that continues. We continue to think about that. So people who have essential appointments might be people who are undergoing chemotherapy and who just have to be seen, or essential appointments could be people who are having an acute experience, acute meaning, emergency sort of abdominal pain, or again, pain in their chest. These people need to be seen, and so you need to streamline differently than you do for other scenarios. We quickly saw that the healthcare community moved to telehealth appointments, and this has been invaluable. They were clunky in the beginning, and they have really come a long way in these past 9 weeks, but we have been amazed at how much we've been able to accomplish via telehealth appointments. But these appointments do indeed require preparation. We can get to that a little bit later as well. Then we postponed a ton of appointments, but because they were not emergent. But what we're finding now is that things are beginning to open up and be rescheduled. And what we've also found is almost a reverse reaction, in that people have stayed home when they should have sought care. So we are listening to hospital presidents and physicians begging people to come in if indeed they are experiencing chest pain, or they are experiencing something that they previously thought was an emergency situation, because people have had strokes at home and they've had heart attacks at home and they've not sought care. So I just wanted to emphasize that if you need care, please seek it. You could go on to the next slide in terms of planning. So then we started to think about, okay, how do we plan for in the event that we are symptomatic, or our clients are symptomatic? And so we proactively reached out to the primary care physicians of all of our clients and our own, and we wanted to know what their protocols were. And again, these protocols have been changing over the past 6 weeks. In the beginning, people were dissuaded from going in to see a physician, but plans needed to be made for testing. And of course, at that time, testing was really not readily available. I am pleased to say that has really that has evolved. And so I had the great pleasure yesterday of interviewing a leader of a large physician practice, has over 100 primary care physicians, and she was describing that, depending on people's symptoms when they call, they make different clinical decisions. So is this someone who just needs a test because they have some symptoms, but they're relatively stable? Or is it someone who actually does need to be seen and need to be evaluated? So that might be a different scenario to do both the test and a clinical evaluation. Do they need to go to the hospital because, maybe there's something emerging that's, could be critical? So different scenarios now. So I recommend that you repeatedly, every now and then, check in with your primary care physician and say, what is your protocol as of now? And use your patient portals to communicate. They have really utilized patient portals much more effectively and redeployed a lot of resources in these primary care practices to respond to people. Then we talked about, well, what do you need to have in your home? And I think it's absolutely critical that you have a few things at home. One, of course, is a thermometer, so that you can, again, pay attention to yourself and gather data and share information with your physicians when you're calling. And so thermometer is critical. You also, we did not recommend this in the beginning, and then about 6 weeks ago, I started to recommend this to everyone, and I was so pleased to hear the physician yesterday say that she's recommending this, but we are recommending that people actually have pulse oximeters in their home. A pulse oximeter is the little device that is placed on the tip of your finger when you go in to see a physician. And what that is measuring is your oxygen level in your blood, and it's also measuring your pulse. And the reason this is, I think it's very important, is because with this atypical pneumonia and this cytokine storm, people who are experiencing a decrease in their oxygen levels are not presenting in terms of symptoms the way that we're used to. So, a normal O2 saturation level is about 94%. And if you get low, in the low 90s, high 80s, generally, you're kind of gasping for air. What we're finding is that with this particular presentation of COVID-19, people's oxygen levels are going down much more slowly. And so therefore, they are not presenting with those symptoms. And by the time they develop those symptoms, their oxygen levels have been silently going down, and they really are an emergency situation by the time they might seek care. This is something called silent hypoxia. So being able to monitor your temperature, monitor your pulse ox, your oxygen level, monitor your pulse, because as your oxygen level is going down, your pulse is going up and your blood pressure might be going down. So if you've got some of these pieces of equipment in your home and you're gathering this data and you're able to continuously be communicating with your physician as symptoms are changing, that can be invaluable to clinical decision making. Of course, many people have a severe flu at home and never get into that emergency type situation. And so being able to manage the symptoms with things like Tylenol and Advil and things that you would usually use to manage a cold are important to have at home. And then, of course, cleaning, products and gloves, especially if you may be caring for someone else. The next slide, please, about planning for hospitalization. So now we also started to think ahead and say, what if our clients need to go to the hospital? What if we need to go to the hospital? Everything we planned for our clients, we planned for ourselves. One of the things that is so different in this pandemic is that individuals have to go to the hospital alone. Now, in our normal line of work, I usually recommend that you never go to the hospital alone, never send a loved one alone, always have an advocate by your side. But in this scenario, we cannot have that. So that was one very important thing we had to plan for. We also had to plan for maybe not going to your preferred hospital. And what I mean by that is, again, there's been a redeployment of resources around the state. And in the event one hospital is full, you could potentially be going to one that does not have your medical records. So that's important. So therefore, we wanted to prepare our clients to be sharing baseline information with emergency personnel in the home and throughout their hospitalization. So we recommended the development of what we call a grab and go kit. And so we can go on to the next slide. This grab and go kit is just a plastic sleeve that has some documents in it that hopefully you either have on your refrigerator or easily accessible. And here are the contents that we recommend. The first is that there's a face sheet that has the name of the person, their address and phone number, their date of birth, any allergies, and an emergency contact. Again, remember, this person is going alone. So the emergency contact, their name, their phone number, their email, and their text information. Another important piece right on that face sheet is what I call what you should know about Sam or Mary. And if we go on to the next slide, let me describe what I mean about that. Again, remember, we have a lot of clients who are in the community who are managing, multiple conditions. So what I mean about this is just a short note with some specifics. So for example, one of our clients, Sam has Parkinson's disease and needs medication every 2 to 2.5 hours or else he cannot move. Sam ambulates with a rolling walker. Sam has had multiple hip surgeries and therefore hip precautions must be maintained. Sam is extremely hard of hearing. Please be sure his hearing aids are in or stand in front of him so he can read your lips. Mary has macular degeneration and only has peripheral vision. And Mary has some cognitive decline and therefore becomes confused easily. Something very simple, but just gives a sense of what's going on with this individual. Now, the grab and go kit should also include, again, next slide, please, a detailed list of your medications, including dosages and over-the-counter medications, a list of your medical conditions. I also like to include past surgeries and hospitalizations. and a copy of your insurance cards. And you can go on your patient portal and download your med list and your medical conditions list so that you don't have to reinvent the wheel. Just make sure the information is accurate. Now, the other things that I think should be in this grab and go kit are a signed HIPAA release form. And these documents, Harry's going to discuss in detail, so I'm just going to mention them. Signed HIPAA release, a healthcare proxy, medical directives, medical orders, and a durable power of attorney. And then we also like to have people have like an overnight bag, especially for some of these people who live alone, packed. For our client with Parkinson's disease, it's got a little bit of extra medication in it. Make sure a phone charger is in it. Make sure the phone is going to go with them, or maybe an iPad, maybe a pad and a pen, things like that. Glasses, glass case, hearing aid case. So again, just thinking ahead. Now, the next slide, please. So now we're going to move into the home. Now, what if you actually have a loved one, first of all, who's suspicious of COVID-19, because you should act as if they have it until such time as you get a test result, or what if they do have it? And I just want to say about this slide that I think that we are asking so much of your average person who is not a healthcare provider to care for a person at home. We're asking people to practice, infection control protocols that I learned in nursing school, and that I've been trained for, and yet we're asking people to do this in the home. And so again, here, think about things. Identify a sick room if you can in the home that hopefully has a separate bathroom. Wear a face mask when interacting with someone who's ill, and if possible, if they can wear a face mask as well. But sometimes people who are having some, difficulty breathing or coughing, that's difficult for them. Again, dispose of anything in a lined trash bag. Do not share things like utensils and bedding. Wash things thoroughly using bleach. Clean and disinfect all the high-touch areas. In fact, we recommend that you do this even for average living. If you're sharing door handles and you're sharing, the microwave, just routinely going over areas, and use EPA registered disinfectants, and I do have a resource for that. And again, gather and document data so that you can continuously be in touch with your physician if indeed you're managing someone at home. The physician yesterday said to me, so important, hydration is incredibly important for people who had COVID-19. And, there are even positioning recommendations that people should be lying on their belly because it really helps them with their lungs and to oxygenate. In fact, she said that, again, the pulse oximeter, she was emphasizing that, just saying that it's the oxygen level and the heart rate that are the two biggest indicators that you might be losing ground with a person who's being treated at home. Okay, next slide, please. I am watching the time. So now, but what if you do have a loved one in the hospital? You can't be with them. And we at Healthassist are all about relationship building in healthcare, relationship building with your primary care physician, with your primary care practice. But what you have to do when you have a loved one who goes to the hospital is you've got a relationship build over the phone. And it is doable, but it's harder. And so you need to begin that relationship building right from day one, from the first moment that maybe somebody goes to the hospital. So maybe emergency personnel come in the home, your loved one goes to the hospital. I'd say give about 15 to 20 minutes, and I would call the emergency room, and I would say who I am, and, my mother or father is on their way to the hospital. I'd like to talk to the nurse who's caring for them. I have information to share. Sometimes, again, remember that HIPAA release form hopefully has gone with them, but sometimes you can say, I've got a release form, I can fax it to you. When can I call back? And you want to try to get to the nurse that's caring for your loved one and begin relationship building and communication. You'll eventually want to speak to the physicians and whatever. But one thing I just want to emphasize is you have to continuously relationship build, because you go from the emergency personnel in your home to the emergency personnel in the emergency department, and then maybe your loved one gets transitioned to a clinical unit, and then maybe they go to the intensive care unit, and then maybe they come out of that, and you're being transitioned to different teams all the way along. So again, you have to start from square one sometimes, and again, continuously relationship build and develop ways that communication can happen proactively with you. And this is challenging during these times. Again, use of technology can be invaluable. And again, you'll be talking with nurses, physicians, and sometimes there's a designated point of contact on these units to communicate out to the family. Sometimes it's a case manager, sometimes it's someone else. You can go on to the next slide. And I just list some resources here. I think the Centers for Disease Control have had incredible resources on their website. And then I also mention the state resources because, again, lots of information about testing and all kinds of things are listed on your state resources. I've got a EPA list of disinfectants. I thought that was valuable. And then I thought there was this wonderful article about this woman who was caring for her husband in New York City. She was a New York Times editor, I believe. And I thought her story was so poignant that I included it here because she was a lay person who did an amazing job caring for a very sick husband in a very small space. So I thought that was a good one. So let's go on to the next slide. And so, you know, we kind of, at Healthassist, where we always joke and say that we act as futurists. We're always anticipating, you know, what comes next for our clients in terms of their health. So I just put a few thoughts together about what I foresee to be the future. I fully foresee that we will experience waves of infection as we open up our economies and as the seasonal impacts occur. We might see a dip down in the summer. We might see a resurgence in the fall. So I think we just have to be ready for these waves of infection. And I was so pleased to hear the healthcare professionals saying they will not be caught, unprepared again. They are preparing for the waves of infection to come. I think we have to be prepared for complex medical conditions that are going to be present in people who may have had COVID-19. We have a 57-year-old man who experienced COVID-19, was hospitalized, was ventilated, came off the ventilator, but unfortunately during that time experienced a very severe stroke, had a pulmonary embolism. He's now in rehab, and I'm thrilled to say that he made his way there, but he will be managing chronic conditions for the rest of his life. And so we are thinking ahead about those kinds of things. We are definitely experiencing a mental health crisis. We are seeing increased incidence of people experiencing anxiety disorders, depression, increased alcohol use, violence in the home. We just have so much going on. I did mention medical bills and insurance challenges. Oh my God, forgive me, but I anticipate a mess going forward. I'm trying to coach people to document everything, keep their bills, keep their explanations of benefits. I think we're going to have to do a lot of troubleshooting of bills going forward. I don't know what's going to happen with insurance premiums. You know, originally I thought, oh my God, that must be going up, but actually other care that is costly has gone down. So we'll see what happens with that. But we are definitely have experienced a changed healthcare delivery system that will be changed forever. This physician yesterday anticipates that 50% of our visits in the future will be telehealth visits. So that's a major change. And then lastly, I just wanted to mention the ethical issues. I've been doing a lot of these webinars, and we've had a lot of questions around what if I don't want my 92 and 93-year-old parents to ever go to the hospital? How do I arrange for that? What if I don't want to ever be placed on a ventilator? What if I have to take a loved one off a ventilator if they don't improve? So again, a lot of issues surrounding the ethical issues surrounding healthcare in general, but they're just enhanced with all of this. So with that, I am going to stop and I am going to transition the presentation to my colleague, Harry. So Harry, why don't you take it away?
Okay, thank you very much, Diane. That was incredibly useful. And you finish with the ethical issues, which may could be a webinar on its own, I believe. So maybe we'll do that in the future. So lawyers, of course, estate planning lawyers, of course, are all about planning as well. And in some ways, it's a lot simpler than the healthcare planning because there's just really a few documents that we think everybody should have in place. And once they're in place, they're in place. Of course, it's a lot harder to get them in place right now because some of them need to be notarized, some of them need to be witnessed, and that's harder to do. And often it can be limited on who you can have as the witness. For instance, if you're appointing someone, they can't be the witness. So that makes it harder if people are sheltering at home. All the more reason to get these in place when you can. And I'll talk a little bit more about it later, but there is a new law on the books that allows virtual notarization and witnessing that allows us to do Zoom conferences basically to do the witnessing and the notarization, but it's unfortunately rather complex. So we're doing those, but it's a little hard. But really the three documents I think everybody needs are a durable power of attorney, a healthcare proxy, and a HIPAA release. And I'll talk a little bit also about DNR orders and MOLSTs, which are more medical than legal, but you should be aware of them. So the durable power of attorney, I've always said, is the most important estate planning document anyone should sign. And what it does is appoints an agent or agents to act for you on financial and legal matters in the event you become incapacitated. And so they can step in and they can pay your bills, they can take care of your investments, they can, if you have to sell your house, they can sell your house, they can sign contracts, whether that's signing a contract with a home care provider or with a admissions to admission agreement to a assisted living or to a nursing home, or any other kind of contract can be signed by the person with the durable power of attorney. Next slide. So you can appoint one or more people on the durable power of attorney. Probably the advantage of appointing more than one is that you have some backup. So if one person is not available, the other is available. They should be joint agents, not meaning that they each can act independently, so you don't have to get both signatures on every single document that they may sign. You can even have more than two people, but once you start expanding beyond two, I think things get a little cumbersome because just the communication becomes more difficult. But you can also appoint successor agents. So a successor agent is when the first agent can't serve for whatever reason, whether they become incapacitated themselves, they pass away, or they're just not around, a successor agent can step in, though that becomes a little more difficult because the person on the other end who is receiving the durable power of attorney needs some evidence that the successor is in office now, has taken that position. And so if the first agent or agents have passed away, then it's pretty easy. You can show a death certificate. But if they have become incapacitated, that gets more difficult. Or if they're just not available, that also becomes difficult to show unless they resign. So often you want, if the first agent can't serve, that you want them to resign so the successor agent can step in. Another reason why I often prefer joint agents, so you don't have to deal with those issues. Next slide, please. The next issue with the durable power of attorney is whether it takes effect immediately when it's signed or it takes effect only upon your incapacity. And you might say, well, why not just have it take effect when I become incapacitated? Because while I have my own capacity, I don't need it. And that would be called what we call, as a term of art, is a springing durable power of attorney, one that springs into effect when you become incapacitated. Despite that good logic, we almost always just have it take effect immediately. And the reason is very similar to the issue with successor agents. How does the person receiving that document, be it a bank, a financial institution, or anyone who you may need to sign a contract with, know that it has taken effect? How do you prove incapacity? And why do you want to make the person who's going to use it at the time they're dealing with everything else having to do with your illness have to go through this process of proving incapacity to use it? So in most cases, if you trust your agent to act in your best interest, hopefully you also trust them not to act in your best interest until it's necessary. And if they do start using the power of attorney when you don't want them to, well, that's a good marker that maybe that's not the person you want to appoint, and you should revoke the durable power of attorney. So 95% of the durable powers of attorney we do for clients are effective immediately rather than springing. So let's see. So next slide. Oh, we got it. Okay, you're ahead of me. So the so one problem with powers of attorney, unfortunately, is they're only as good as they function in reality. I mean, if you take it to a bank and the bank doesn't accept it for whatever reason, then what good is that piece of paper? And that is a problem. So banks often and other financial institutions are wary that somebody's being defrauded and that the power of attorney may not be effective. And so they put a lot of hurdles in the way of their use, which is quite unfortunate. But there is a workaround, fortunately. A lot of these financial institutions have their own power of attorney forms. So we advise our clients that in addition to filling out a general durable power of attorney, appointing their agent, if they do work with Charles Schwab or Fidelity or Vanguard or any other, or Bank of America, any of these companies, ask them if they have their own durable power of attorney form, and if so, sign that as well. And even though there's probably no legal difference between the two documents, they like their own. So so that's a good solution and something you can do ahead of time to make sure this will work. Next slide, please. So healthcare proxies are very similar to durable powers of attorney in that they appoint an agent to act for you to make healthcare and medical decisions when you are not able. Now, one difference is, at least in Massachusetts, is that they are always springing. They only take effect when a doctor has determined that you are incapacitated and cannot make your own medical decisions. Another difference is you can only appoint one agent at a time. But those are the main difference. Otherwise, you're still appointing an agent to make decisions for you. Now, some states don't call them healthcare proxies; they call them durable powers of attorney for healthcare. But it's the same thing basically. You're just appointing an agent to make those decisions for you. Next slide. So one problem with that kind of all the research says about durable powers of attorney for healthcare or healthcare proxies is you've appointed this agent to make these very important decisions about your treatment, your life-sustaining measures that will be taken to take care of you or keep you alive. And what does that agent know about what your decision would be in that situation? People often don't talk to their healthcare agents. So there are a number of solutions to that. One is to include instructions of some sort, either in the document itself or in a separate document, which would be called a medical directive. The problem for most people is, while they can say generally, for instance, I don't want to be kept alive on life-sustaining and receive life-sustaining treatment if I'm going to become a vegetable afterwards, or if the success is very unlikely, that doesn't really apply to any specific situations. And unless you're a doctor, you may not have enough knowledge about those situations to make decisions in advance. So you can give really sort of more general guidance to the agent. There is a living will is a kind of medical directive, but it's narrow. It was kind of the first document that was developed when substitute decision making started coming along some decades ago. And that is really just a medical directive that says withdraw life support if I'm in a coma or in a vegetative state, or those are kind of the main situations, or I'm in such a situation that there's going to be little benefit from any treatment. The other document that I think can be more useful there are a number of workbooks. One of them is from an organization called 5 Wishes, which do talk about your values, allow you to answer a lot of questions and provide a lot of information that can guide your agent. So they can talk about your values. They ask you questions about your values, about what your decision would be in specific circumstances. So we actually offer those to all of our clients so they can fill those out and have them available to their agents, and I think allows a lot more in-depth discussion. And speaking of discussion, the other thing is, well, just talk to each other. And Ellen Goodman started a program called the Conversation Project at theconversationproject.org, which has a lot of aids to help people talk about these issues. And it's not just, and this is broader, and the 5 wishes is also broader than just medical treatment. It also talks about, well, what kind of life do you want to live as you get older? If you no longer have the capacity to make all these decisions yourself, do you want to stay in your house? Do you want to move to a retirement community? Do you want to move to a place that's warmer rather than colder? So those are also decisions that are in discussions that are part of the conversation project and 5 wishes. Next slide, please. The next document is the HIPAA release. Now, a HIPAA release is a document that allows medical people to talk to the people you name on the HIPAA release. And you may say, well, I've got a healthcare proxy. Why do I need a HIPAA release? And the answer has to do with some of the limitations on the healthcare proxy. So the healthcare proxy, as we said, only takes effect if you've been declared incapacitated, and it only appoints 1 agent at a time. So if you are hospitalized, or if you have to go to the emergency room, the person who may be able to accompany you or may be visiting you in the hospital may not be your healthcare agent, just because of scheduling and logistics. And of course, if you're in a hospital, you're there 24/7 as long as you're there. And again, the healthcare agent may not be able to be there all the time. So it's very important to be able to facilitate communication with medical personnel and institutions. And the HIPAA release allows you to do that, allows you to name all the people that you would want to be involved in your medical care, or at least have access to be able to talk to medical people. So while the healthcare proxy names 1 person, we encourage our clients to name as many people as they would feel comfortable having this access on their HIPAA release, so that they all have access and they can all work together on that. So those are the 3 really important documents that we recommend to all clients: the durable power of attorney, the healthcare proxy, and the HIPAA release. Next slide, please. But I'll say a couple words about DNR and MOLST. So DNR is a do not resuscitate order, and that says basically, if I have heart failure or I stop breathing, don't resuscitate me, because you may know those are often pretty violent events, and if you're already kind of pretty ill, or you don't have much cognition, maybe you don't want that to happen. And those have been around for a while, and those are signed by doctors, and that's something you talk to your doctor about. That's not signed by a lawyer or prepared by a lawyer. So more recently, in a similar kind of pattern of starting with a living will and then moving to broader medical directives and healthcare proxies, a new document has been developed called a MOLST, which is a medical order for life-sustaining treatment. And again, this is something you would discuss with your doctor and complete with the doctor, and the doctor would sign, which basically talks about what kind of treatment you would like in any number of situations that are described in the MOLST document. And so that's something to talk, if you're 40 years old and in perfect health, you're not going to be doing a MOLST. But if you already have some ill health and you want to have some control and make some decisions about what your health care will be going forward, this is something you can develop with your doctor. And Dianne probably knows more about these things than I do, being a nurse. So next slide. So I'm going to turn this back to Dianne and go through the summary, and then hopefully we'll have some questions.
Great. Yeah, I just wanted to say that the thing about the DNR and the MOLST forms that I always have to coach clients about is that they do facilitate communication, and they can change. So I have clients who fill out a MOLST form one way, and 2 years later we do it again, and they change it just based on their condition changing. So all of these documents that you just described with regards to the medical directives and the living wills and the 5 wishes and the conversation project, they really do promote communication, but they also promote what I call iterative decision making, because especially with older adults, there's numerous decisions before you get to the point of do not resuscitate. So things like, inserting feeding tubes and all kinds of things like that. So, all right, I needed to add that.
Thank you.
So, yes. So, in summary, I just wanted to say that we encourage you all to continuously read and become educated because, again, one of the things I learned yesterday in our, well, I knew this already, but she reinforced it, this physician, is that although physicians normally are practicing according to defined clinical protocols, there is a lot of just-in-time learning that is going on with this new disease. And so clinical protocols are constantly evolving. So please stay educated about all of this. Again, I cannot emphasize prevention enough. In the beginning, I remember thinking, oh, if I got it, I'm pretty young. I'm well, not that young, but I'm healthy. I'd probably be fine. I don't feel that way anymore. I feel like it's really, really important that we attempt to prevent ourselves from getting and contracting this disease and or spreading this disease because we just don't know enough. Again, can't emphasize planning enough, both on the part of medical planning as well as legal planning. And, relationship building is invaluable. It's even more important these days because it has to be done via some form of technology and maybe just a regular phone. But be creative. I have to say the healthcare community has really ramped up and is being very creative, and they've loosened the HIPAA requirements these days, such that they are doing Zoom calls, they're doing FaceTime calls. So just be creative with the communication in order to promote that relationship building. And so I think that that's about it. So Beth, do you want to kind of take over and let us know whether there are any questions?
Yes. Sorry, I was on mute. Thank you, first of all, to both of you for all of this. It's really helpful. And, there's so many things to think about and to prepare, not just during this pandemic, but I think this thoughtful approach can really help us all stay organized and hopefully ahead of any challenges. So I've been tracking. There are a lot of questions. I'm not sure we're going to have time for all of them. So I will start with the first one that came in. Our children are out of state, have only scanned copies of our documents, including durable powers of attorney and healthcare proxies. Will these copies be accepted by medical and financial institutions? For hospitals, do we bring only copies of important things like driver's license and medical insurance cards?
So I'll answer the first question. So the copies should be accepted. But if they're not, you should make sure your children do have some access eventually to the originals. But again, with respect to financial institutions, we do have the issue that some of them can stand on ceremony. So it's important if you have an existing relationship with a particular financial institution, I advise also executing their durable power of attorney. But in terms of what to bring to the hospital with you, I'll defer to Dianne.
Sure. Well, I think we went over much of that with the grab and go kit. Again, I would say that yes, bring your medical insurance cards and or copies of those cards. It doesn't even have to be the card. Yes, you might want to bring your license so that you can a person can be identified. I always worry about things getting lost as you're going from transition to transition in a hospital. So I worry about originals for anything. The HIPAA release form, again, invaluable. And I just want to mention too, Harry, that HIPAA release form, that is what we as healthcare advocates, healthcare advisors use, a client signed HIPAA release form. So it's another good use because now, information is going to be shared with another third party who's not even your healthcare proxy or a family member. So multiple uses for the HIPAA release form. So I think we mentioned everything that the questioner asked.
Oh, okay. So let's go to the next one. If you're asymptomatic and living alone, self-isolated, under what circumstances does it make sense to be tested?
Well, I think if you have symptoms, I think you really need to begin communication with your physician to begin to decide whether or not testing is indicated. There's always the question about, well, if a person is positive or negative, does it change the clinical treatment? And I would say that the clinical treatment might be the same in the beginning, whether you know if you're positive or negative. But if you know you're positive and you're monitoring your symptoms, and you're providing data to your physician, it might impact the recommendation. So, for example, if somebody needs to be seen because they maybe are experiencing some shortness of breath, but maybe they don't need to go to the hospital emergency room, what some clinical practices have done is they have designated COVID-19 respiratory clinics. And these clinics within their practices are taking, incredible precautions. And maybe you need to go and maybe you need to have an x-ray or chest x-ray or whatever. So I would say that, knowing whether you're positive or not certainly impacts clinical decision making a little bit further down the line. I was so pleased to hear that, testing is more readily available. So I do recommend you communicate with your physician and make decisions together.
Okay, so this is just a two-part. Just give me a second here. So my 87-year-old mom is in ALF. She has mild ALZ, COPD, ovarian cancer, macular degeneration, severe hearing loss. In 2018, she started withdrawing large amounts of cash from bank, not knowing it could impact Mass Health app someday. Since she had failed her driver's test, the bank suggested that I keep her license so she could no longer withdraw cash. So now with COVID, she does not have an ID if she needed to go to the hospital. Thoughts?
Well, this might be more for Dianne, but it sounds to me like it makes sense to prepare a grab-and-go bag, including a copy of her license and everything else that should be part of that.
Yeah, no, I totally agree. I'm sorry, I got distracted and I didn't hear the last part of the question. Could you repeat it again for me, Beth?
Yeah, so she doesn't have an ID
Okay.
because the mom doesn't have an ID because the daughter has it in her possession. So what happens if she has to go to the hospital?
Yeah, I mean, I do think that's why we do that grab and go kit with, you could put a copy of the ID in the grab and go kit. You don't have to have the original. And I, just like having all of the identifying information right on the front of that grab and go kit. That'll be important for emergency personnel who are coming into the home, to start that communication. I think that's the way you could manage it.
Okay, so can you clarify how springing versus immediate plays out for an adult who is well and autonomous? So Harry, I think that's for you.
So that's probably referring to the durable power of attorney. And the idea basically is, even though the power of attorney is effective when signed, the intent is that it's not going to be used until necessary. So that's the reason to do it. And again, we don't want to do a springing one just because it creates more hurdles to prove that it has sprung, that it's effective. And so the only times we ever do springing durable powers of attorney is if perhaps the client doesn't have someone they totally trust, basically, to name as an agent, but they do have somebody they would want to appoint just in case. There are kind of estate planning orphans out there who don't have anybody to appoint, but somebody who has somebody they could appoint but really doesn't want them to act too soon. We might do a springing power of attorney in those cases with very specific definitions in the document of what it takes for it to be effective. When we do that in our documents, we actually usually have a place on the document itself for a doctor to sign saying that the person has become incapacitated. So it's not effective until that signature is placed on the original document itself. But we really, as I said, in 19 cases out of 20, we use immediate durable powers of attorney. One thing I was going to talk about and I forgot to is the issue of how do you get these things signed today? because in the old days, we'd prepare documents and clients would come in and we'd sign them, we'd provide witnesses, we would provide notaries, and now we don't do that because we're trying to social distance. So so there are a number of different workarounds. Some documents actually don't need witnesses or notaries. We put them on in large part just to make them look more official. And so in those cases, we can prepare documents that don't have those. But some documents do need notarization and witnesses. Wills need witnesses. Healthcare proxies need witnesses. Most wills are also notarized because if you have a notary, it just makes it easier when it comes to probate the will, something called a self-proving affidavit. Trusts do not need to be notarized or witnesses in most cases, but if they're going to be recorded at a registry of deeds, then they do need to be notarized. So we can case by case decide what documents need to be notarized and witnesses, and rather than just doing it for everything as we would in the normal practice. The other thing is, as I mentioned, there is a virtual notarization bill now for the duration of the pandemic. It is a bit complex in terms of what you have to record the session on Zoom or GoToMeeting or Skype, whatever app you're using, and keep that recording for 10 years. And then there's some other steps you have to go through. If you're dealing with a deed, you actually have to have 2 recordings, 2 sessions to do that. So we're beginning to do those. Healthcare proxies are interesting in that regard. As I said, they need to be witnesses, but not notarized in most cases. But the notarization legislation, interestingly, allows for virtual witnessing, but only in connection with notarization, not on its own. So in those cases, we're actually now adding a notary seal to healthcare proxies, even though they don't necessarily need to have them. But the other thing we've done a lot of is what we call drive-by document execution, where we've had people meet in our firm parking lot, and everybody stays in their own car and are connected by conference call as the client signs the documents, and the notaries and witnesses observe the signing. And we've had a number of clients come to at least one of our attorneys' homes, and she and her neighbors stand out on their porches to witness the document execution in the client's car. So we're trying to be creative to make things happen during the pandemic.
So we do have a lot more questions, but they're fairly in depth. So I think that probably best to have you guys answer them after, and I'll pass all the information along to you.
We'll be happy to do that.
We're a little over on time. So I want to thank everyone for attending. Thank you to Dianne and Harry. And you've seen our contact information. This is for Healthassist and for Margolis and Bloom. And hope you enjoy the rest of the day and stay healthy.
Thank you, Beth. Thanks, Harry.
Yep.
Bye, everyone. Okay. Bye-bye.